colleagues who have been still present at the last session, last couple of talks. My topic is a little bit different, but as we are going with the theme of this session, we are seeing the non-pregnancy topics which rarely occur in pregnancy, but we shouldn't miss. So missing it will definitely cause one life or two lives. So what we'll be discussing about the DKA and severe hypoglycemia, and also a few information on steroid and IVF trigger hyperglycemia and pregnancy. Hypoglycemia pregnancy, you will see next speaker will be discussing a little bit in detail. Okay, so as the prevalence of GDM is increasing, what we have seen in yesterday also and today, we are now seeing more and more cases of rare complications in diabetes. So diabetic ketoacidosis is a big term, but what we are commonly seeing in pregnancy, and what you shouldn't miss and you shouldn't be sometimes alarmed of, is the routine ketonuria or mild ketonemia in pregnancy. That is again very common in first trimester when vomiting is going on, and similarly when patients are prescribed hypocaloric diet. What the earlier session was there, in obese women, especially when you prescribe this, you get some kind of ketonemia and ketonuria, and that is not good for the baby. So very important thing, you have to reduce the 30% of estimated calorie requirement for obese patients with pregnancy, and this is important, and you shouldn't be alarmed when a single urine acetone is present in your patient's lab report, but you must investigate and identify the serious proper diabetic ketoacidosis. If you see the ketoacidosis, diabetic ketoacidosis precipitating factors, these are 5 I's: infection, infarction, indiscretion, and insulin deficiency. And what we are discussing is infant on board. So infant on board is again our important thing, that is where pregnancy stands. Pregnancy itself is a risk factor for precipitating diabetic ketoacidosis. Though it complicates less than 5% of all pregnancy, with pre-gestational and gestational diabetes, the maternal mortality is extremely rare. What we are concerned about is the fetal mortality rate up to 35%. And type 1 diabetes patients who are usually very uncontrolled and becoming pregnant, they are at higher risk of having more DKA. The predisposing factors you can see are pregnancy itself, but what are the main factors or pathophysiological factors in pregnancy that predisposes for ketosis? These are placental lactose and prolactin. They are anti-insulin agents, human chorionic gonadotropin also. When there is gastroparesis also, malabsorption, increased metabolic rate, which requires more glucose. Buffer capacity is decreased, like renal excretion of bicarbonate, which makes the pregnant one more prone for acidosis. And what precipitates is the MSCs, again very common: infection, trauma, stress, failure of insulin regimen, again very important. When we want to escalate the treatment and when we are not doing, again as a fear of hypoglycemia, what the next talk is all about. Again, this is a failure of insulin regimen, and it can precipitate ketosis also. Corticosteroids again are given very commonly in pregnancies. We'll be discussing that. Tocolytics agents are given like beta mimetics, which again produce more insulin resistance, and secretion of glucagon is also increased in pregnancy. So all these, then the common pathway is similar for non-pregnant DKA or DKA in pregnancy. So diagnosis, again, the criteria are similar. The biochemical or metabolic criteria are similar. But important thing what we miss is the overlapping symptoms, which are in pregnancy also and which are in DKA or early DKA also. So we all know nausea and vomiting and abdominal pain. These are the common initial presentation of all diabetic ketoacidosis. And these are almost present in all pregnant women. So we need to be highly suspicious of this. We need to see the insulin and glucose control also if the patient is taking proper insulin. Other symptoms, like you can see, tachypnea is already there. Tachycardia and hypotension are already there during pregnancy. But we want to discuss is the Kussmaul's bleeding, severe abdominal pain, when you have ruled out the other causes of nausea, vomiting, always, or patient is not hyperemesis gravidum, not responding to treatment, always check for ketones. Complication, as I said, for maternal side, mortality is very rare, but pulmonary edema and cerebral edema can be there. Fetal complication is all what we are worried about: fetal distress, perinatal death, hypoxic or hypoglycemic brain injury, and long-term developmental impacts are there if there is chronic acidosis. Again, management of DKA in pregnancy is similar to what we do in DKA. The thing is, IV insulin still remains the key. We have to give by infusion only. 0.1 unit per kg per hour is what we start, and we need to increase also depending upon the blood sugar levels and the fluid balance and the acidosis response. Again, IV fluids and potassium replacement therapy are the key. As with routine decay, there is no different thing. What is important is the identification and treatment of the cause. Okay, so this is again very important for non-pregnant decay and here also, but in pregnancy we need to be detected very early and aggressively treat the cause, because otherwise we have two life cycles. Similarly, patient monitoring needs to be more 1 hourly RBS one. We can go for electrolyte every 4 to 6 hourly when it is required. And fetal monitoring, this is an additional aspect when added. So this is where we require a proper obstetric gynecologist or a fetal medicine expert for this to confirm the viability, the monitoring for heart rate, also ultrasound whenever it is needed. And sometimes if you think the DK is not responding despite all our efforts, aggressive efforts and proper efforts, sometimes termination of pregnancy is needed, what we see in other PIH cases also, where termination leads to resolving of the DKA. But I think I have not heard or not seen a case of this kind of severe DKA, and this will be only possible in type 1 diabetes becoming pregnant. So we have not gone into any encounter like this, but sometimes very extremely rarely if early delivery or termination is needed. Severe hypoglycemia during pregnancy, this is again a talk coming. Our next speaker will be seeing a whole talk on this. The thing is, we have so much maternal consequences and fetal consequences. Again, similarly, we can see severe hypoglycemia occurs. The mother can lose consciousness. She can have seizures or convulsions. She can have traumatic injuries if she falls down in home, and sometimes road traffic accidents while driving also. And sometimes lasting cognitive fog is there. Patients' cognitive function is reduced or reduced mentation is there for longer period of time if she goes into severe hypoglycemia. But fetal distress, growth retardation is there if the chronic hypoglycemia persists. Okay, there is again a stress and lesser insulin behavior is there, what we will see discussing in next talk. But if your patient is going persistently in the hypoglycemia, low grade hypoglycemia, then the growth retardation, small for gestational age, is very common. And similarly, neurodevelopment, neuro abnormalities, maternal coma and seizures, what we already discussed. But for fetal also, chronic hypoglycemia is important. And there are hypoglycemia unawareness. You must have heard the term. This is both common, especially in the pregnant woman who are type 1 diabetes, because they already have hypoglycemia awareness, many of the patients. And similarly, during the first trimester also, due to the altered counter-regulatory hormones, the usual patient also have hypoglycemia unawareness. That's why if you see, fasting blood sugar up to 63 is considered normal during pregnancy also, up to 60. So this is what we want to take into consideration, hypoglycemia unawareness. That's why they are more prone to go for severe hypoglycemia. So again, let me focus on this slide first, that routinely what we see less than 70 is level 1 hypoglycemia. So ADA and EASD, they were joint committee on hypoglycemia, and they will describe this level, especially for clinical trials also. So what they've done, they've done the criteria for non-pregnancy. You can see less than 70 but more than 54 is level 1 hypoglycemia, or they also call it sometimes clinically alert level. Okay, they sometimes they don't label it hypoglycemia. It is called clinically alert level, but level 1 hypoglycemia. Level 2 is when your blood sugar level drops below 54, and level 3 is what we call severe hypoglycemia. That what we are discussing right now is the event characterized by altered mental or physical status where patient requires assistant to treat the hypoglycemia. This is a key word. Okay, patient cannot self-treat hypoglycemia, then he or she requires some assistance from other person, relatives or doctors to treat the hypoglycemia. It is called level 3 or severe hypoglycemia. But in pregnancy, 63 is fine. So hypoglycemia education is important. We'll be discussing more detail, but you need to explain, because all these patients, suppose patient of GDM coming to you, they have never taken any medicine, sometimes never taken any injection also prior. So when you are starting with insulin in GDM, you have to explain hypoglycemia in the first day itself. Okay, how to recognize hypoglycemia if they are on getting hypoglycemia, how to treat it with rapid acting carbohydrates, 15 to 20 gram. They can keep dextrose tablet also. All type 1 diabetic patients, ideally, as in Western countries, are requested or guided to keep glucagon injection also. We have a affordability and storage issues with glucagon, so it is not widely available, but you can still get it. So all type 1 diabetes who are prone for this severe hypoglycemia, they should keep glucagon injection, who are very prone for hypoglycemia due to hypoglycemia unawareness. So this is the simple hypoglycemia level 1 and 2 management. Step 1, we know, eat rapid acting carbohydrate. Step 2, check again. So this is where mistakes occur. We don't check after eating something if your sugar level has gone above 70 or not. And third step is don't skip the meal. You have to take your next meal if the time is due, or eat something carbohydrate containing snack if your meal is due. Severe hypoglycemia management, this is where it is important. If the patient is able to access glucagon, otherwise they have to call emergency service, because no relatives can give IV drips. Okay, the IV glucose, intravenous glucose is very important thing. Always educate your patient not to give some liquid drops or limbu pani with sugar when patient is unconscious. It will definitely put them into aspiration pneumonia. Okay, so first thing is patient is not responding, just call the emergency service or just call the neighborhood doctors, which we have all Indians are privileged to have some neighborhood doctors. But in night, our 108 service is very, very helpful. So once blood sugar level is above 70, you have to check it also and eat the next meal. Last few slides for glucocorticoid induced hyperglycemia. So this is where when we are expecting the early delivery, so for fetal lung maturations, you must have seen steroids are very commonly given. Okay, these are lifesaver for the baby, but when the patient is already having hyperglycemia in pregnancy, deteriorates your glycemic control. Okay, so term we need to understand steroid-induced diabetes also and steroid-induced hyperglycemia. Steroid-induced diabetes is patients who are here taking steroids for many years for other indications, and they develop proper diabetes. But what we are discussing is steroid-induced hyperglycemia for short term during the last few weeks of gestation for fetal lung maturity. When we give it, we see deranged glycemic control, sugar vadi gaya. Okay, so for diabetes, it leads patient maternal hyperglycemia is there. Ultimately, it leads to fetal hyperglycemia and fetal hyperinsulinemia, and later on, immediate postpartum, we see fetal neonatal hypoglycemia also. This is the reason if we give glucocorticoids antenatally and we don't manage it, it will ultimately lead to fetal hypoglycemia. So management wise, this is a chart, but this is nothing. It says what we are doing, we need to intensify. So there is no separate treatment for steroid-induced hyperglycemia and pregnancy. Suppose patient is, this left side is chart is for well-controlled patient, right side is for the poorly controlled patient. So patient only on medical nutrition therapy, we need to intensify it. Patient who are not controlled on MNT, poorly controlled, we can add a short-acting insulin. So usually, how does it last? It lasts usually 72 hours. Dexamethasone and betnazole, what we give, the common hyperglycemia is 70, but some 72 hours. But some patient, we can see the deranged glycemic control up to 1 week. So we have to monitor. I missed the slide. So monitoring is key. So whenever uh, your our gynecologist friends they give injections, we in Surat we have very good practice that all they inform to the patient that your sugar level is going to be increased. So this is one thing. Second thing, when they are not checking, I think as the guidelines are aggressively screening GDM, whenever we are giving a patient betnazole or dexa, we should screen them for this spike. The thing is, this is very limited time, and patient usually don't come for follow-up after these two injection to each of visit. So monitoring is key, and our in Surat, our all gynecologist friend, they strictly say you go to your doctor and your sugar levels are going to increase. All my pregnancy and diabetes patients are in directly phone contact with me, so usually it is well taken care. But don't miss this opportunity to monitor this hyperglycemia. And whatever dose you are taking, we just need to escalate the treatment. Okay. Suppose patient is on basal insulin, we either increase basal or sometimes you want to add a bolus premix, we need to intensify the dose. And if it is not controlled temporarily, we may have to shift to basal bolus treatment also. Lastly, we are now seeing more cases of ART induced hyperglycemia. The thing is, we don't have any separate guidelines. As the IVF use is increasing globally, more and more patients are having higher obstetric complications also, perinatal risk also, than who are at spontaneous pregnancies. And women who conceive with IVF, they are around 21% higher risk of development of GDM as compared to spontaneous conception. The current GDM guidelines lack any specific recommendation for IVF treating the IVF-induced hyperglycemia. So most existing studies are very small scale and systemic reviews only. And this ART-induced hyperglycemia in pregnancy treatment is similar. Very important thing, we need to be doing early screening and preventive treatment. Early screening is very, very critical. Even we have seen from 8 week only. Preventive treatment, what Dr. Avichandan sir just mentioned, we need to be doing preconception optimization. So for all IVF patients, it is critical, in my point of view, exercise and weight loss. We have now wonderful drugs with weight loss, and with preconception weight loss, we can definitely reduce the chance of new onset diabetes during pregnancy, and early and aggressive treatment protocol is required for this kind of pregnancy. Thank you so much for kind listening.